Okay. We're starting to catch up. We will catch up. The next one is minor head trauma. Minor head trauma, a big topic, as you know. And there's some literature on here. I'm going to tell you about some of the important ones of these articles, including some that aren't in your chapter, but I'll tell you where they are, because we've done them since this chapter was written. And but unfortunately, this is not one of those where there's going to be easy answers. So the first thing that's important to know about is, what is minor head trauma? How do we know what it is? What does it mean? What's important head trauma? What's a concussion? What are all those things? Well, first of all, people write about it. They mean different things, and that's sort of weird. So how would you define minor head trauma? So you can define it by outcome or by what it looks like. Okay, so in terms of outcome, some people define minor head trauma as a GCS of 15. Some people define it as a GCS of 14 or 15. Some as 13 to 15. I've never heard worse than that. Some people define it as no loss of consciousness. Some people define it as normal. A GCS of 15 isn't normal, you know. I mean, you can be normal and have a GCS of 15, but you can be abnormal and have a GCS of 15. So there's a very variable way in which people look at this. In addition, you can look at the outcomes. Was there something that needed a neurosurgical intervention? That's not minor. How about it doesn't need a neurosurgical intervention, but it needs some other intervention, like watching in the ICU for 2 days, or intubation? How about just it's an abnormal CT scan? Well, those are all different, and if you look at the literature, people use different versions of those. So I'm going to start out by saying that to me, what would matter is, can we identify, because this is all about missing cases with something bad. Looked minor, ended up bad. So for me, what I want to know is the thing that we would have missed important? And is it important not from the standpoint of it's bad for the patient doesn't like it, because there's a lot of minor head trauma where the patient doesn't like it. We're going to talk about that in a minute. When I say important, I don't mean we should trivialize the ones that I'm going to call non-important. They're important to the patient. What I mean is it important to me that I don't miss it? And for that, it has nothing to do with, is the CT abnormal? Because the CT is often abnormal in ways that don't matter. They don't affect what I do. So I want to know, is there a finding on the CT that matters to me, that's going to change how I behave? And even that's sort of a little silly, because 10 years ago, we behaved differently for the findings that today we behave in a different way. So for example, a little tiny subdural 10 years ago went to the OR. And nowadays, little subdurals don't go to the OR. And we're probably going to change a lot of the things we do over time. And it's not just that we change them because we know you don't have to go to the OR, but it's also because we have different tools. So if you start doing more and more 200 million slice CT, you're going to find really little subdurals and little contusions and all sorts of stuff that we're not going to know what to do about because we didn't used to find it with the less good tools. And in fact, even if you think about it, CT scans versus skull films, if I think of the 30 years that I've been a doctor, the most important change in medicine, I think, has been CT scans. I think it's the thing that's changed my practice more than anything else. We have all this stuff about everything changing, but CT scans really changed my practice. It's a huge advantage over skull films, which is the way we used to look at head trauma. But you know what? It also comes at a cost, because we find all these things that we didn't find before, and they did okay, and now we do something about them. So that's just sort of as a background. So I think it's important for us, when somebody looks like they're minor, that we don't miss something that we have to do something about. When I say that, let's really be clear, though, that we don't have to do something about concussion in general. But that doesn't mean we should trivialize the notion of what a concussion is. So what is a concussion? You all use the term. What does it mean?
Whack on the head with lasting symptoms.
A knock on the head with lasting symptoms?
Yeah.
So what kind of lasting?
Something that lasts more than a few minutes.
Something that lasts more than a few minutes. What kind of things?
Loss of consciousness, loss of memory.
Loss of consciousness, loss of memory, nausea, Okay, so somebody comes in and they're comatose. That's lasting symptoms. So the traditional definition of a concussion is just the reason. You're right, of course. It's something where, for some reason, the patient gets there. But the traditional definition had two parts. One was the symptoms all get better. It's transient neurologic symptoms. And the second was there's no anatomic abnormality. If you look in old textbooks of neurosurgery or neurology, that's what a concussion is. So it's sort of like magic. They had a symptom, but we don't know why because there's no anatomic abnormality. Now, of course, and it all gets better. And we now know that concussion is neither of those two. If you get a better microscope, a CT scan, a better CT scan, an MRI, you find that all concussions have an anatomic abnormality. There's some stretching of the veins. They have a little bit of microbleeding. They may even have a little bit of cerebral contusion that we didn't see before. And the second thing is they don't get all better. In fact, we all know about the post-concussion syndrome. A post-concussion syndrome lasts for days, weeks, months. It isn't transient. And how often does it happen? Well, at least 75% of concussions. So a concussion is an event where I don't have to do something about it because there isn't a macroscopic problem on the CT scan. I'm not going to do any intervention. Well, I may do interventions, but not as an emergency doc. The intervention may be follow up with the patient or reassurance or something like that, or let them know that they're going to have headaches for 2 weeks or 6 weeks or whatever it is. I think it's really important to know that concussion symptoms are very common, and they're often disabling for patients. Not really in the macro scale, but in the micro scale they're disabling. The patient just isn't right. They feel funny. They're having nausea. All these things that are troubling to them. If you sprain your ankle, you have symptoms 3 days later, it still hurts, you don't think I'm going to die. It's just your ankle. You know you bruised it. It's no big deal. You sprain your brain, and 3 days later you're still feeling dizzy. You feel like, wow, my brain, something's wrong. One of the things about concussions is symptoms wax and wane. So I'm feeling better, and then it comes back. It's really terrifying to patients. You've got to let patients know that. What do we do instead? We give them a head sheet. They're having headache, nausea, dizziness. We send them home and say, call us if you're having nausea, headache, or dizziness. It's nuts. We also tell them, wake little Johnny every hour and see if he's irritable. That is like my favorite discharge instruction ever. And then we get sort of pissed off that they came back. Why did he come back? Because we told them to come back. So there's a much more rational way, I think, to deal with concussions. But in any case, this chapter isn't about that, even though the first two articles about sports concussions, when do they go back to work? And the only thing I'll tell you is if you do this and you're a team doctor, you have something like that, you should know what people are saying are the rules. But you should also know that they're entirely made up. There's no evidence that any of this is correct. So the first one and the second one are about what is the general notion of people who do this type of work about when a kid can go back to sports if he's on the team. But, you know, that's all I'm going to tell you about it because it's really, there's no science to any of it. The next thing is, how do we know in all the people who come with a little bump on the head that they're really okay? That we don't have to do a CT scan, for example, because we don't want to do a CT scan on everybody. And we'll talk about that in a second. But in addition, they then break it down to overall with, quote, minor trauma. Secondly, kids. Third, the very elderly. Fourth, special situations like anticoagulation. So we'll just go through that very quickly now. Starting with, why don't we want to do a CT scan on everybody? Well, first of all, we charge patients a lot of money. It doesn't cost anything, but we charge them a lot of money. Second, it slows up your department, right? That's a real big deal. And third, we're now learning that there's a lot of radiation in CT scans, and it's probably not a good idea, especially in young people who are going to have lots of CT scans over their life. And some of us aren't going to be around to see the effects of our profligate use of radiation. But I really suspect that in 15 years, we're going to start seeing cancers, lots more cancers from all the radiation we give. There is one article in here, I don't remember which number it is, but you can find it easily. It's sort of a weird idea, but it's really important. It's about, it was done in Sweden. They had all these people who had a hemangioma on their face when they were a kid in the 50s, and they got radiation for it, and then they saw how many of them got to high school. compared to their peers who otherwise were exactly the same, just didn't have a hemangioma. A hemangioma had no reason to have any systemic or cerebral effects. All that was different was they got radiation. The amount of radiation they got is less than we give in a modern CT scanner. And the more fancy scanners we get, the more radiation there is. And so they looked at this, and in those days, in the 50s and the 60s, getting to high school in Sweden was a big deal. So it's sort of like, did you get to good education or not? And they found dramatic differences in the people, much, much less in the people who got their facial hemangioma radiated. Doesn't prove anything, but it's a little worrisome, right? A young brain subjected to a large amount of radiation, maybe there are effects on that brain. Not to mention the possible effects of cancer. We don't really know how much radiation causes cancer, because all we really have is Hiroshima.
Are you saying an impact on intelligence, or are you saying they didn't survive an impact?
No, intelligence, okay? All of the measures of intelligent function, of cognitive function, were less in that group. But it's also, how about cancer? Well, from Hiroshima, we know that lots of radiation causes cancer, and people have made all sorts of extrapolations about how far you were from it, how much from the bomb blast, and how much you're likely to have. And there are these Bibles. There's something called Gray's Bible of radiation effects, which tells you how much you need to cause cancer. And generally, it doesn't mean that you actually cause cancer, but rather the risk increases per amount of radiation. So if you get X number of 5,000 chest x-rays, your chance of getting an extra cancer is 1 in so many. And the amount of radiation we give with CT scans, abdominal CT scans, 3 pan-CT scan for trauma is huge. And it comes out to, the estimates are, you pan-CT scan somebody young in life, young people have trauma, you're going to increase the chance of a cancer in 1 out of every 1,000, something like that, 1,500, something like that. Well, in this room, we see lots and lots of people like that all the time. And for every 1,500, 5,000, whatever it is, we're increasing 1 fatal cancer. That's a lot. That's a lot. We do lots and lots of CT scans. So we shouldn't do them if we don't need to do them. That's not to say we shouldn't do it if we need. Of course we should. But we shouldn't do it profligately. We should be careful about how we do it. So that's the subject of this chapter. And what does it say? There are a bunch of people who have looked at people with minor trauma, which ones, when they got a head CT scan, ended up having something that we cared about. Now again, some of the studies say which ones ended up having an abnormal CT scan. I don't really care about that. Some of the studies say minor trauma is they had to have loss of consciousness. Other ones say no. There's all sorts of different rules. In addition, one of the most famous studies from Canada says you had to have a GCS of 13 to 15. Now, I don't know about you. I'm really big on not getting CT scans if I don't need it. But there's no way in hell I'm going to take somebody with a GCS less than 15 and not scan them. I'm just not. We know there's lots of literature that if you have a GCS of 15, there's the occasional person who ends up with something important. If you have a GCS of 14, it's a few percent. It's like 1 in 20. If you have a GCS of 13, it's like 1 in 7. That's not the way I'm going to save on scanners, myself. It's a little different if they're drunk. And I'm thinking the reason that their GCS isn't perfect is because they're drunk. Even there, if you decide not to scan them, you know you're taking a risk. So you have to have another strategy, which is going to keep following them and make sure that they get better, et cetera, et cetera. But if you work in a place with a lot of drunks, you can't scan them all. And you can't scan them every day when they come back with drunk and a little bump on their head. So you have to have a strategy. But in general, I think, a GCS of less than 15, I don't consider in the same class I consider GCS of 15. Now let's go to the GCS of 15 and see what the rules say. Now I'm going to read you some stuff here, not because I want you to remember it, but just because I hope it will make an impact on you. So here is the Haydel or New Orleans rule. It's 7 criteria. GCS 15, these you don't have to scan, okay? This is what the rule says. GCS 15, normal neurologic exam, no persistent antegrade amnesia, no intoxication, no physical evidence of trauma above the clavicles, not older than 60, no seizure, no headache of any sort, no vomiting, and no coagulopathy. Okay, who can tell me what the rule is? There's no way. You can't, I don't think you could ever use a rule that complicated. I really don't. But in any case, that's what the rule is. You could have a card, you could look at it. But that's only one rule. Okay, here is the Ian Steele rule from Canada. It says there's a 5-part rule that's really good. That is failure to reach GCS of 15 within 2 hours, a suspected open skull fracture, sign of a basilar skull fracture, vomiting at least twice, age greater than 65. All these are a little different than the Haydel rule. And then if you want to get a little more, there's 2 other factors that you could use, like amnesia before impact of at least 30 minutes. And mechanism of injury, dangerous mechanism of injury. And then there's a whole list of what a dangerous mechanism of injury is. I don't think you can remember that, and it's different than the other one. And then I'm going to tell you what the nexus criteria were. Okay, we just did nexus. We had a big 14,000 patients, and we came up with criteria that are, oh my God, it's somewhere. It's here somewhere. I can't remember what it is, and I wrote it. It can be collapsed into 5 different things, and they're, I'm not even going to tell you. It's okay, but it involves mechanism of injury and recurrent vomiting and history of coagulation. And is there evidence of a basilar skull fracture? There's a few things, okay, but all of these are slightly different from each other, and they're all complicated. And what do they actually all show? They all show that if you follow these rules, you will pick up almost all the people who end up having a bad outcome. Not all, but almost all. And you will be able to decrease your CT scanning by a little. So you'll do a few less scans and you'll have a few more misses. Now, some of these articles were published in famous journals like the New England Journal. We presented our paper not as, here's a great rule, but as a, it looks like we couldn't come up with a rule that's much better than clinical judgment. Because we couldn't. We could pick up almost all the injuries, but at the cost of, we'd miss an occasional one, and we'd still do 90% of the scans, 85% of the scans. And we thought, that's probably not a great trade-off. And not only is it not a great trade-off, it's probably going to be worse than not a great trade-off if you misuse it a little bit, and it's really complicated, and it's hard to use well. And by the way, when we tested the other guys' rules, they didn't work very well in our data set, which is why each of us came up with slightly different permutations. They all say the following are important, and here's what you should take home. If there is a lot of vomiting, that's probably bad. If there is persistent alteration of consciousness, behavior, that's really bad. If there is signs of a basilar fracture, that's probably bad. There is this one other thing I'm going to tell you about in a second, which is there a hematoma on the scalp? And that's the one that kills me because, one of them, the New Orleans rule says any trauma above the clavicles. How's that going to save me CTs? That's going to increase the number of CTs I do by a zillion, right? Well, most of them don't say that. They say, is there a hematoma on the scalp? But they don't say how bad a hematoma. A big hematoma, a little hematoma, a tender hematoma. Some of them say, well, frontal hematomas don't count. A lot of people bang their head and it's no big deal. It has to be parietal or occipital. But nobody can agree on all of these things. So you see, a bad hematoma, I'd worry about that. The other thing I worry about, the really big one, is coagulopathy. And we're going to talk about coagulopathy in a second. I'll get back to it. It's the most important, I think, because it's not so straightforward. But in any case, I really don't think we have this down. And what's more, I don't think we're going to get it down. I don't think there's going to be any rule that does a lot better than what you already know. As long as you don't just order CTs on everybody who bumped their head. As long as you're using these types of factors to help you decide. By the way, there's a few articles about in peds and the same type of lousy results. The UC Davis group just came up with a peds rule, which is 5 parts, which included any headache, any vomiting in kids. As far as my experience is, if you look at a kid wrong, they vomit. I've never seen a kid with head trauma who didn't vomit. How could that be part of a rule that's useful? I don't understand it. We didn't have in the Nexus database any vomiting, but we did have a Nexus database which said, do you have at least 2 vomit? At least twice. Is there recurrent vomiting? When we used that on our kids in Nexus, they missed 15% of the important injuries with the Davis rule. Now, to be fair, that doesn't mean the Davis rule is wrong. It might be right. We couldn't test it. But if you change it to, is it vomiting I'm worried about, it doesn't work. So this is really complicated, and I'm not sure there is a simple answer. And it may not be that having the decision instrument really is going to help us any more than using our brains a little bit. And by the way, it's not the only place in medicine. There are lots of places in medicine. There are places where we can do better. The auto-ankle rules is better than clinical judgment. So is Nexus. It really will tell you there's a group of patients you don't have to do it. Nexus 1 for the C-spine. But not this. I can't tell you one for the head. Now, I want to get back to coagulopathy in a second, but first there's a comment or question.
I'm just going to ask about what about extreme elderly patients?
The extreme elderly is just like coagulopathy. It's just like the alcoholic. They all have lots of space in their brain. What happens when you have a concussion is you get a little bit of bleeding and you tamponade it off and it's over. You have some symptoms for a while, but you're not going to go on bleeding. Who violates that rule? The person who has lots of space, or the person who's coagulopathic. An elderly alcoholic's got all of them, right? So they're really at risk. And we know that's really bad. They're also at risk because we don't like them, and because they're there again, and they've been in 5 times again. I'm going to keep radiating his head, but they're really at risk. So you have to keep that in mind, because when they have a little bleeding, they're going to have more bleeding. In Nexus, coagulopathy, which we defined as, doctor, when you're filling out the form, are you worried about this patient being coagulopathic? Because they're on a medicine, because they're an alcoholic, for whatever reason you think they're coagulopathic. It wasn't based on an INR. It turned out to be a very important predictor. It was one of the key predictors of, yes, something bad happened. But the important stuff, and it's a couple articles in here on the same topic, the important thing was it didn't predict an abnormal CT scan today. It predicted a bad outcome in the next few days. And I think that, to me, is the most important thing about coagulopathy. People who cannot clot, when they have a little blood, they keep bleeding and bleeding and bleeding and bleeding, and eventually they get into trouble. So the real truth about coagulopaths is that you got to worry about them, and you got to violate the other consistent rule in all of the CT literature, which is a normal CT gives you a clean bill of health. It does in everybody except for the elderly, the drunks, and the coagulopaths. If the CT is normal now, you're fine, unless you're going to keep bleeding. And that's why these people are so problematic. They are at risk now, but they're not at any more risk than the rest of us. They're at the same risk for an acute subdural. They're at much more risk for a delayed subacute or chronic subdural. So the worst thing you can do, a lot of people say, should you get a CT? I don't think you have to, but I do think you ought to be cautious in these people, and if you want to get it, I certainly think that's fine. If the only reason is coagulopathy, you can. But the most important thing is you don't fool yourself into saying, well, the CT is normal, they're okay. Because the real risk isn't now, it's tomorrow. And the problem is it's not only tomorrow, it's next week as well. So you could put them in the hospital, but you're going to have to send them home sometime, and they could have a delayed bleed a little bit later. If they have no good follow-up, no good social support, that's a real problem. If they have good social support, the most important thing is not that you did the CT, but that you made sure that they're followed regularly. The good news with the brain is if you take an animal and you squirt in blood or put a grapefruit in there, you don't have to put a very big grapefruit to cause herniation. You don't have to put in a lot of blood. But if you do it slowly, you can have enormous grapefruit and they won't herniate. The time that it takes to build up pressure is tremendously important in the brain. That's why people have these huge meningiomas before they even know that they have any symptoms. In the same way here, if they're bleeding slowly, you have time to figure it out. But only if you've made a safety net. So the real thing for most coagulopaths is to make a safety net, to make the best safety net you can. If there's no safety net, they're a drunk on the street, it doesn't matter what you do. You could put them in the hospital, you could do a CT, they're still at risk when they go home. There are lots of other little details, but I'm not going to go through any of them because I think I've really covered the big details. Any questions or comments or thoughts?